just want to say thank you for being here, and hopefully it's not too hot by you. It's getting pretty hot here in Iowa, but we are surviving and thankful for air conditioning where it exists. So yeah, thanks for being here with us, and this is the Essential Substance Abuse Skills webinar series. I'm Kate Trans, and today we have our dear associate Matt Ignacio presenting on client, family, and community education. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which will include a link to the recording, handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. Immediately following today's webinar, you will be redirected to our Gipper evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar, so please use the chat pod to share your questions and comments, and we'll address questions at appropriate points during the presentation. And just so you know, if you want to view the presentation larger, you can click on the full screen button, which looks like 4 arrows pointing outward. And to return so you can see the chat and interact there, just press that button again. So our speaker today is Matt Ignacio. Many of you, if you have joined us for webinars before, might be familiar with him. He's one of our regular trainers, and he's a member of our advisory council, and he was the curriculum coordinator on our Native LGBTQ and Two-Spirit curriculum. And we are currently working on updating that, and Matt is a part of that as well. And we are planning out dates where we will be piloting that, and so we're looking forward to that, and I hope that some of you will keep your eye out for that curriculum to come along as well. Matt has also served as a lead author for a 2013 Centers for Disease Control and Prevention funded publication. Oops, sorry, Matt, I think we're getting the clicking on the wrong layout here. Just let me get back here a second. So the publication that Matt was the lead author for is titled Action, Compassion, and Healing, Working with Injection Drug Users in Native Communities. His prior work also includes the National Native American AIDS Prevention Center and as a project manager, and the Michael Paul Center for AIDS Care and Support and Gay Men's Health Crisis, the first and largest AIDS services organization. He's currently a doctoral student at the School of Social Work at the University of Washington. So thank you, Matt, and I apologize for the super long introduction, but I'll pass things over to you at this time.
Great. Good morning. Hopefully you can hear me well. My name is Matt Ignacio, and I'm a member of the Tohono O'odham Nation. Good morning to you from Seattle, Washington, currently on Coast Salish land, the Duwamish people's land. And I'm excited to be here to talk about client, family, and community education. So let's kind of just talk briefly about what I will cover. I want to talk about HIV prevention and frame this discussion in HIV prevention because it is directly related to substance abuse prevention and treatment. We'll talk about some common sexually transmitted infections, and explain core components of communicable disease prevention, right, on individual community levels. We'll talk about some factors that kind of place people at higher risk It will cover some strategies that substance use providers, direct service providers, counselors, therapists, community members, I mean, the list goes on, strategies that we can use to prevent HIV, sexually transmitted infections, and viral hepatitis. So it's a good day to talk about all of this. Just a quick background, 2019, so it's been exactly 20 years that I have worked to address HIV in American Indian, Alaska Native, and Native Hawaiian communities. So I'm really excited to keep this conversation at the forefront because, I don't know, I guess the last few days I've been thinking about HIV prevention and where I've been and the work I've done, and feeling like sometimes, oh, HIV feels so not as important or doesn't get enough attention, or maybe the days of the HIV crisis are behind us, and because treatment is out there now. And I realize that that's me being complacent. That's me getting lazy about the wellness of our communities, right? Native communities. Whenever any disease or any traumas or contemporary traumas or harms are introduced into our communities, they matter. They impact because of the size of our communities, which are smaller. As American Indian, Alaska Native individuals, that's 2% of the entire United States population. And so when we think about something like HIV entering a tribal community, or syphilis or gonorrhea entering a community, we're putting a lot of people at risk. So given the small size of the communities. So that's kind of where my perspective and lens is going to be centered this morning. This training, or this workshop, or this webinar rather, this morning is covering core competencies 106 and 105. So to be able to understand and describe the health and behavior problems related to substance use, including the transmission and prevention of HIV, tuberculosis, sexually transmitted diseases, hepatitis C, etc. And also to describe the principles and philosophy of prevention, treatment, and recovery. The number of people living with HIV infection in the United States is higher than ever before. About 1.2 million people in the US are living with HIV by the end of 2012. Of these people, about 13% do not know they're infected. And we're looking at about 50,000 new diagnoses each year. Consistent increases may be due to a higher proportion of people living with HIV infection and knowing their status. So in other words, maybe we're doing a better job at getting people tested. We also know that folks are living longer with HIV, living long, healthy lives, actually. HIV is no longer a death sentence, is how it's often referred to as, because of treatment, because of medications, because of where we are in biomedical technology to help folks live longer and healthier lives. Folks are living longer. And becoming infected with HIV, then the number of people who die each year with HIV or AIDS is also an issue, and factors into the increase, what looks like is an increase in higher proportion of people becoming infected or who are infected. Looking at the United States by region, we have the West, Midwest, Northeast, and the South. And as you can generally see, the South looks to be far more impacted by HIV diagnoses. And that also could be a product of better surveillance, better testing, better outreach to getting folks to know their status. Nonetheless, we also know that the South is a higher population of African American communities living in poverty, that being risk factors, social determinants that can place people at risk for HIV. Here's another slide looking at breakdown with regard to race and men who have sex with men. So men having sex with men as a risk category for acquiring the disease, we see that white men who have sex with men is greater, followed by black MSM, Latino, and then moving on to risk categories of black heterosexual women, black heterosexual men, etc., etc. Most looking at routes of transmission. So how does someone become infected with HIV, right? So the most common way folks become infected with HIV is sex without a condom or sex without a barrier, right? Followed by sharing previously used syringes and needles and for HIV, but if we're talking about hepatitis C, we're also factoring in tourniquets, cotton, other injecting equipment like spoons, lighters, anything where blood can be a part of. That's hepatitis C risk factors. For HIV, we're specifically talking about sharing and reusing syringes and needles. Almost eliminated ways are ways that we no longer truly see HIV transmitted in this country is around, through occupational accidental exposure. So needle sticks on the job. Most places, I think, or most healthcare facilities are aware of how sharps containers can prevent unintended accidental exposures. We now see that technology of a sharps container being placed in community-based organizations. We also see even sharps containers in casino bathrooms, in tribal casino bathrooms, for diabetics, to safely dispose of syringes so folks don't get accidentally stuck. Think of the custodians who work in those bathrooms, or even other customers or clients or participants coming in and putting their hand in the trash can and getting stuck. Those are few and far between, generally speaking. We also do not see very often transmission through blood transfusions or receiving a blood transfusion. The screening for blood products is much greater than it has been, particularly as a result of the HIV and AIDS crisis. And so we don't see that very often. That could be different if you're in a different country, but as far as the United States is concerned, that's one way we don't really see HIV being transmitted anymore. And also mother-to-child routes. So it is a risk factor through breastfeeding, particularly if it's a newborn. Within the first couple days, the newborn's stomach lining is very sensitive and can tear, and HIV can be present in breast milk, and so that presents a risk. But with right care and right consultation with medical providers, we can take steps to prevent HIV being transmitted from mother to child. There is a sequence of events when someone is exposed to HIV. You initially could be asymptomatic as your body is producing more and more of the HIV virus in your system, which gradually leads to a depletion of T cells, CD4 T cells, which are your fighter cells, which fight off infection. And as more of those T cells are diminished, then you can now enter a phase in what would be a formal AIDS diagnosis, in which your T cell count drops below 200. In addition, you could also reach a formal AIDS diagnosis if you happen to have what is known as an opportunistic infection. And there's a set list of what those infections are. Thrush, as a rash, pneumonia being another opportunistic infection. There's a list of different infections you can get that would automatically formalize an AIDS diagnosis. Okay, this is what's known as the treatment cascade. It's a very famous cascade in the last probably 5, 6 years, and it really kind of highlight the takeaway I get from this slide is the importance of treatment, right? So if you could just generally look on the left side of the bar graph, that is the proportion of folks, the number of folks who are living with HIV. Now, as you move to the right, you notice that the proportion, the number of people gets smaller. So of the folks who are infected, there is a slightly smaller population of people who actually know their diagnosis. Of those people who know those diagnoses, there's a slightly smaller proportion of folks who are actually linked into care, who have HIV doc, or who has somebody that's able to prescribe HIV medications. That's a smaller proportion of folks. Less than that, you have a smaller amount of people who are actually retained into HIV care. Less than that, you actually have a smaller amount of people who are needing antiretroviral therapy and then who are actually on it, followed by the smallest proportion of folks who actually are carrying or have undetectable viral loads as a result of being on medication. And so you can see kind of the, I don't know how you want to phrase it, but like the span of where we are, generally speaking, the amount of people who have HIV, to where we want to be, which is the number of people who have undetectable viral loads because they're on proper treatment and getting the care they need. So as you can see, there's work that has to be done. Thinking about treatment, HIV treatment as prevention, research has shown the values of antiretroviral therapy treatment. We know that there's reduced viral load, can significantly decrease the likelihood of transmitting the virus. So quite literally, the treatment is so effective that it actually reduces the amount of virus in your body. And if you were to engage in unprotected sex with somebody who is HIV negative, you then are less likely to transmit the virus because it's very undetectable in your system, right? And that is a direct result of medication. A person not living with the virus can now take HIV medications to actually protect themselves from infection, right? So it's the flip. If you're HIV negative and you engage in high-risk sexual behavior, you can take the same medications that people who are HIV positive take, and it can help prevent the onset of becoming HIV positive if you're exposed to the virus. So it's almost like kind of in the general direction of what we might think of as a vaccine, but not, because you have to take it daily. I think the adherence rate, you have to be adherent. You have to be able to regularly take the medications on a daily basis. Otherwise, it doesn't work. Otherwise, you might introduce resistance to the virus if you're skipping doses. But these are ways that we can think about treatment as prevention. Certainly, another intervention is linking folks to care. So structured programs to move people from diagnosis into stable care is what we refer to as linkages to care. We can help folks work through barriers, fears, and misconceptions. We can help folks walk through administrative barriers. When do you sign up? What are maybe some of the documents you might need? How do you get those documents? And navigating environmental barriers. How might transportation look like? Do you have childcare? Those sorts of aspects of linking to someone to care, we can talk about. Any one of us can address and help folks work through. Also means evaluating available care options, looking at issues around insurance and Medicaid and Medicare and affordability. And not all programs are required for all people, but should be required for all programs. LTC programs, linkages to care programs, maybe not everybody needs them, but I guess maybe this should be phrased as we should be mindful of them and offer them as to offer a buffet of options for our clients. Now let's take a look at sexually transmitted infections. Given more general categories of bacterial sexually transmitted infections, we're speaking of gonorrhea, chlamydia, and syphilis. We know that there are great antibiotics that can cure those infections. There are parasitic infections such as pubic lice, or crabs as it's also known as, and scabies, which isn't, scabies is not necessarily a sexually transmitted infection. It's more of a skin-to-skin, but certainly folks can acquire scabies through sexual behavior. Also, great antiparasitics that can help cure those ailments. And then there's viral infections. So human papillomavirus, HPV, HIV, herpes simple complex, and hepatitis A, B, and C. Treatable, but not necessarily curable, right? And certainly preventable. Hepatitis C, specifically, newly infected are either asymptomatic or have mild clinical illness. The HCV RNA, or the molecular structure, the molecular chemicals can be detected in the blood within 1 to 3 weeks after exposure. And the average time from exposure to antibody seroconversion, from antibody to HCV seroconversion, is 8 to 9 weeks. Chronic hepatitis C infection develops in 70 to 85% of those who are infected. 60 to 70 chronically infected individuals can develop evidence of acute liver disease. And most infected persons remain unaware of their infection because they are not clinically ill or presenting with symptoms for a very long period of time. Here's a quick snapshot of new hepatitis C regimens. This particular slide is not my area of expertise, but it's important to know, and I'll just highlight, that this journey for hepatitis C cures and treatments has been a long road. I can remember back way prior than 2013 when there were clinical trials for medications, and it would work with some populations and it wouldn't work with other communities. For example, African Americans. And I think because of a different genotypes come into play with regard to treatment. And I think now, where we are today, has been an amazing outcome of a long journey of folks who have dedicated their careers to finding treatment for hepatitis, for folks who are living with hepatitis C. This is also really relevant to the community at hand, right? American Indian, Alaska Native, Native Hawaiians, other indigenous folks, because very often we see high rates of alcoholism, high rates of alcohol use. So it's important just to kind of be mindful of all the different, I guess you could say, all the different trials that Native people go through, but then also being mindful of the different healing and wellness strategies that exist out there. Briefly, just talking about HIV and hepatitis C co-infection. If there should be routine testing for hepatitis C for any HIV positive person, and certainly early diagnosis, evaluation, and treatment should be considered for HIV positive patients. That's something that we would want to talk to a specialist about for sure. Looking about prevention. Thinking about your program specifically, do clients receive education, get referrals, or actually have risk screening and counseling available on site? Knowing that there's vaccination available for hepatitis A and B, and knowing that there are services out there that can directly address hepatitis C risk and treatment. Thinking about your program, how much of this is actually discussed, right? Which leads us to knowing that prevention comes first. And this seems like a great pause, actually, before we move into the next section, to take a break and allow folks, if there's any questions or comments, to please use the chat box, and I'll be happy to take any questions or comments. see a few folks are typing. Hope you're having a great day out there, wherever you are. Okay, so go ahead and continue typing. I'm just going to keep moving forward, and I'll be... So Lula Howard asks, what is HPV and how can it be transmitted? That's a great question, and I'm going to direct you to some resources. Lula, just hang tight. I'll send you a link. And then Steve is saying, very informative, Matt. Are the overall cases of HIV about the same in 2012 as they are today? Right. That's a great question, and we will update that data. I know there has been more recent data now. What I can say, just even thinking back over the past 20 years, specifically as it relates to American and Indian and Alaska Native individuals, is that from my personal perspective, because we're doing a greater job at getting Native folks tested to know their status, it looks as though things are getting worse. Because of better surveillance in rural communities, in rural reservation communities, the data now shows that it looks worse, that things are getting worse. I say that, but I also want to say how things have improved and how structural community level stigmas and shame have kind of almost diminished to the point now where we can start talking honestly about sexual health. And specifically, I'm talking about homophobia, biphobia, transphobia, two-spirit phobia. I believe that there's a really robust national reemergence, honoring, if you will. Think of a national two-spirit groups that are all over in major cities, two-spirit societies. And I believe that cultural shift in and among American, Indian, Alaska Native communities, normalizes this discussion around risk, might encourage someone to actually get tested, might encourage someone to know their status, and by that point might inspire someone to then seek out treatment and stay on treatment and live a healthy life. So one stat that stands out in my mind where it doesn't look so good is specific to American Indian Alaska Native women who are unfortunately acquiring HIV the most via sharing injection equipment compared to all races and ethnicities. So in other words, out of all races and ethnicities, Caucasian, African American, Latino, American Indian Alaska Native, Native Hawaiian, and other Pacific Islanders, it's the American Indian Alaska Native women who are getting HIV by using shared contaminated injection equipment. That's alarming. That also could be a factor of better surveillance and better testing. But we're also in a culture now where it's more accepting to talk about injection drug use as a risk factor in rural reservation communities. Anyway, that was a long answer, Steve. I totally went with that one. I hope that kind of contextualizes some of the data moving forward. Yeah, okay, so let's talk about prevention. All right, so thinking about interventions, right? Levels of interventions. Intervention refers to the mechanisms or strategies used to operationalize or achieve a level of prevention. So what would you do, for example, what would you do to promote the idea of using condoms among your clients right now? How do you navigate that conversation? How do you navigate that intervention? And honestly, interventions are the opportunities to directly connect with individuals, communities, or systems that are creating or perpetuating risk in order to eliminate or reduce or mediate risk. Another way of thinking about this is that interventions are always trying to change something. Very often trying to change a behavior to promote health or wellness. So what is most effective in thinking about the different levels of intervention? So structural level interventions often are addressing policies and systems. Community level interventions are often addressing community level norms or cultural norms, right? Group level interventions are often trying to address individual behaviors through group settings. So normalizing behaviors, allowing clients to see that they're not the only ones going through what they're going through. And then individual level interventions are often trying to address individual behaviors to promote health and wellness. So which one do you choose? Think about your community and risk populations. What's appropriate for them and the issue? Consider the science, consider the research. What is effective? Thinking about science and research, a really great model that often can help inform program development is looking at the indigenous stress coping model, which highlights cultural activities as a way to prevent harm, as a way to prevent substance use, as a way to prevent HIV infection. And thinking about what is affordable. Very often programs have a hard time trying to figure out how everything will get paid for, right? Particularly in indigenous communities. So a cost-benefit analysis can help you determine what may be best and what might be feasible. So for example, individual level interventions are expensive. However, they are effective. Group level interventions reach a greater, wider audience. You can reach more people, but can have marginal effects, can have sort of like, okay effects in terms of behavior change or change. Community level interventions can certainly reach more people. They often take longer to create any change, but can promote opportunities for lasting change, right? And thinking about structural level interventions produce lasting change and can address root causes, sort of the social determinants I spoke of earlier. Certainly can be complex and challenging and often not supported with federal dollars. So that's your policy work, that's your tribal policy work, that's even tribal policy as it relates to state and federal entities, looking at what that dynamic looks like. Certainly can be very complex, but can have positive outcomes. Thinking about one not necessarily leading to the other for clients, right? Thinking about just because someone had a higher risk incident, perhaps they had a slip last night, they were engaging in sexual behavior, condom wasn't used, that doesn't necessarily mean they were exposed to HIV, right? Just because someone is exposed to HIV doesn't necessarily mean that they are going to become infected. Perhaps maybe that individual is taking medication and perhaps they have a low viral or undetectable viral load. So just being exposed to the virus doesn't necessarily mean a person will become infected. There are cases where folks have been exposed to the virus and they, for whatever reason, did not become HIV positive. Their immune system has fought it off. Those are very rare cases. But also thinking about other sexually transmitted infections, the body does have a defense mechanism. There is a possibility that the body could fight it off naturally. And if someone does become infected with HIV, hepatitis C, or a sexually transmitted infection, that doesn't mean it needs to be spread. Right? There are steps and opportunities, rather, that folks can take to prevent the spread of sexually transmitted infections. All right, so let's talk about substance use treatment providers and how we can conduct HIV, hepatitis C, and sexually transmitted infections. Okay, so there's a quick question from Lula. Is there any data showing how many Native children under the age of 5 are affected by HIV? That's a great question. Off the top of my head, HIV surveillance data, CDC data, where I would look for that, might show HIV infection for ages 13 to 24 and categorize that as youth or call them youth, and that data would be available on CDC's website as it relates to American Indian Alaska Native youth. Under the age of 5, I don't know off the top of my head. Maybe somebody in the room does. I'm thinking maybe mother-to-child data on CDC's website, looking at by race. Maybe there might be some information there. But that's a great question. If I think back to that, I will reach out to you, Lula. Thank you for the question. Okay, so why substance use providers? Why treatment providers? Why is this sort of relevant to the work that we're doing? Well, counselors, providers have experience with behavior change professionally, right? It's part of the fabric of the work that we do. We engage with high-risk clients on a daily basis. Folks that have maladaptive coping mechanisms or have sort of learned to survive this world, the hardships of this world through self-medication, right? We see that very often on a daily basis. Another reason why substance use providers are excellent helpers with regard to HIV, STI, and hepatitis C prevention, because we are able to instill a sense of accomplishment, self-improvement, and value of health seeking among our clients. Very often when somebody even picks up the phone to schedule an intake, let alone follow through and show up for their appointment the next week, those both are action steps. Those both are, how long it actually takes me to pick up the phone to schedule a teeth cleaning because I don't like going to the dentist. That could be months. It could be actually like a year and a half before I get around to doing that. I can think about it and avoid it and put it off, but by the time I actually pick up the phone, by the time your client actually picks up the phone and trying to seek services, that's something to acknowledge, and that's an accomplishment. We should be acknowledging those steps, right? And reduces number of injection drug user occurrences and HIV risk behaviors under the influence. We as providers can talk about safer ways for folks who are not able to stop using. We can be educators on safer ways to use to minimize risk for a lot of drug harm, including HIV and overdose and death. More reasons why we think substance use providers are excellent providers to help prevent HIV, hepatitis C, and sexually transmitted infections is that people living with HIV require HIV treatment and disease monitoring, but they may be hesitant to access medical care systems, require consistent medical monitoring, and may not have insurance or know how to access care. So here's an opportunity where we can help essentially handhold somebody through this process. It can be very scary. And imagine if the shoe were on the other foot and how much a caring individual who took time to help walk you through that process, how significant and life-changing that would be for them. I think that's a beautiful example of why we do this work, right? And service providers can be the bridge to HIV care, essentially. And that, if we're serious about seeing individuals improve, if we're serious about communities' wellness improving, we all play a part in that in different ways. So service providers, treatment providers can be excellent in serving as a bridge to care, linking to care, right? Thinking about prevention as a core function, prevention seeks to interrupt the spread of a condition. Substance abuse, substance use, and sexually transmitted infections can all be prevented, right? And prevention is a core function of public health and behavioral health practitioners. So this current prevention foci is kind of a balance between biomedical and behavioral. And we might even throw in there, I would add another element to this, cultural, right? Sort of balancing biomedical and behavioral interventions so that it is has inclusive of cultural factors that help sustain balance. Behavioral interventions examine individual and community psychosocial components of behavior and implement strategies to change them. And that's very often delivered through interventions. So an individual may go through some skills training on how to avoid using drugs, particularly youth. Individuals might attend a group setting to learn about stages of change or harm reduction strategies. We might think about behavioral community interventions such as syringe exchange, a service where folks can acquire and dispose of syringes to prevent the spread of bloodborne pathogens, right? Those are behavioral interventions. Biomedical involves the use of medical science to intervene in the biological and pathological operations of the virus or bacteria. So this is the treatment side, right? The medication, if you're HIV negative and you take the medication to prevent becoming HIV positive, that is known as PrEP. If you, for some reason, were exposed to HIV and you're HIV negative, I believe you have 72 hours to then access medication to take as an emergency treatment to prevent becoming HIV infected, and that is known as PEP. PrEP stands for pre-exposure prophylaxis. PEP stands for post-exposure prophylaxis. So there's technology out there, but I don't think that that is widely known as I think I would like to see it, or as many people would like to see it, especially as providers, let alone community members. I think even providers may not be well aware of the biomedical technologies that exist today. There's a lot of research around microbicides, HIV microbicides, gels, foams, thinking about vaccination research, HIV clinical trials that are trying new technologies to prevent the spread of HIV, and the circumcision as a way to prevent HIV has also been in the research literature. These are biomedical interventions. So thinking about a combination of both behavioral and biomedical interventions, looking at partner therapy, right? Getting tested, maybe accessing PrEP, and helping individuals stay adherent to medication or treatment plans. Thinking about the family roles. As a primary vehicle for socialization, families can create a social support network, foster access to healthcare, model positive communication and behaviors, provide opportunities for dialogue on the long term, value norms around diversity, de-vilify sex, combat gender norms. I just want to briefly share an example of the family in supporting particularly a mother who was HIV positive, living in a rural part of Colorado, and she had to travel a great distance to see her HIV doctor, I believe once a month. I may have been not as frequent. But initially she was going to see the doc because she wasn't able to stay adherent to her medication, and her health was compromised, and she was having health issues and complications as a result of not being on the medication. And so one thing that she ended up doing was telling her family, her children and the other family members that were living in the house that she was HIV positive. And after she did that, it was the young daughter, the 9-year-old daughter, that decided to use one of the calendars that was hanging in the kitchen as kind of her own medication chart. So the daughter took it upon herself to each day would put an X through the day if the mom took the meds. And so what ended up happening over a very short period of time is the mom was adherent to the medication and her health improved. And the doctor asked, what is going on? How is it you're doing so well? And the mom said, because my daughter has been helping me stay adherent to the medication. And I just think that's a beautiful example of how family can be supportive and how supportive family, whether that's blood related or not, can be supports in terms of improving their own, our community's own wellness and health. Thinking about community further, communities have a responsibility to establish resources and access to resources for HIV and substance use issues. Communities also have a responsibility to create social policies that emphasize health and wellness, equal access, and disallow discrimination, right? Communities have opportunities to shape norms around sex, drug use, risk reduction, harm reduction, and gender expression. Communities have opportunities to encourage sexual and substance use education in schools. I would probably change that word encourage, but mandate sexual and substance use education in schools. And communities have opportunities to create policies around syringe service programs and safer injection facilities. I always say that in this work, I may have a boss, or I may work for an executive director. I may even work under a board of directors, right? But those are never my bosses. Those are never the people that I really respond to. Who I respond to is the community and what their needs are and what gaps are present in the community and how can I play a role in helping the community, again, improve their health and wellness. How can I support a community in developing these policies around creating syringe exchange on their reservation? Those are questions I love to ask. In thinking about systems and the roles they play, systems are the mechanisms through which formal services are delivered. Indian Health Service, tribal health centers, tribal health councils, right? So very often they have a very good understanding of what the community needs are because they interface with the community on a daily basis. If you are a frontline provider, you know, I look up to those folks. Those are the people who have their feet in the fire, who see the trends that are taking place in the community, who know what drugs are being sort of introduced or being widely accessed by community members. So that perspective is really critical and honored, I believe. Systems can align services to community needs and community culture. Very often that's what we try to do. Unfortunately, a lot of the evidence-based practices have to be adapted to native culture and native ways of life. Systems can work to alter potentially harmful community norms. I think of the anti-stigma work around addressing homophobia in rural reservation communities. I think of the Navajo Nation, and they did a really great, excellent social marketing campaign around homophobia, biphobia, probably about a decade ago. Beautiful posters. I know other communities have done the same. Systems can ensure access to services by reducing barriers, right? Systems can design and provide services through a health equity lens. Health equity is is a term you can easily search on the internet and learn more about. Systems provide the list of preventative services and modify systems to accept a variety of insurance carriers. So systems play an important role. We all should be mindful of how these can help somebody or can actually be a barrier to helping somebody. And we certainly want to work to create systems that are not a barrier to helping somebody. Another phrase or another term you might come into contact with is this idea of a community viral load. And it's looking at the community as if it were an individual person. And just like a person has a viral load, a community can have the same. So just by the sheer number of how many people are infected in a given community is considered the community viral load. And thinking about this, on a community level, like what can be done to lower a community's overall viral load? Thinking about prevention, thinking about treatment, thinking about culture. How can we lower a community's HIV viral load? All right, so more succinctly, what can a substance use provider do? What can a counselor do? What can a treatment provider do? On the clinical and individual level, we can include indicators for HIV, sexually transmitted infections, and hepatitis C risk in all of our assessments. We can include actionable items on HIV, sexually transmitted infections, and or hepatitis C in all of our treatment and our service plans. We have opportunities to include family and partners in counseling sessions to discuss risk and provide education. We play a key role to what environmental and social risk to identifying what environmental and social risk factors that contribute to not just drug use, but also sexual health risk. And we can certainly become involved with Ryan White care, management care teams. We can know who the HIV docs are in our community and build relationship with them. And very often that's actually what was a needed step in tribal health centers who wanted to provide HIV testing but didn't have the staff on board who could provide HIV care once a tribal member tested positive. That was not uncommon. So what was required of those particular organizations was they had to develop outside relationships with HIV doctors, maybe in town or in the town adjacent or in the city that they were located in, build that rapport, build that relationship, that trust, so that they could then refer clients to that doctor. Furthermore, on a clinical and individual level, providers can conduct HIV, sexually transmitted infection, and viral hepatitis screening and vaccinations, provide referrals and assist with medical linkages to care, discuss medication adherence, treatment adherence as part of just a general clinical practice, and be able to provide basic HIV and sexually transmitted infection education to your clients. Right, enrolling in those HIV 101 trainings, listening to webinars such as this to widen and deepen your knowledge. Furthermore, what can a substance use provider do with regard to environmental considerations? Create an environment where it is okay to discuss sexual behaviors and identities. Practice not having the look of shock when somebody talks about who they hook up with or who they have sex with. Serving as a conduit for information for individuals and families. You be a channel of information and education on a dime, on a moment's notice. It could be as simple as having condoms available in your bathrooms or at your waiting room or in your office. Reducing the barrier to access to condoms or the price folks have to pay for condoms. I don't think anybody should have to pay for condoms. They're out there. They're not seen, or maybe when you go to the doctors, they're not, maybe they don't put them out, or maybe they don't think to put them out, or maybe they don't think to buy them and put them out. But making condoms available is certainly an important step, I believe. And programming that makes syringes more accessible to high-risk users. It could just even be the question asked. So if you're not a program that is attached or linked with a syringe exchange program, just even asking, do you know where to get sterile injection equipment? Person might say, I don't inject drugs, or yes I do, or no I don't. And now you have an opportunity to educate and inform. It's building that relationship, right? So lastly, let's just talk briefly about integration. This is, I believe, the last slide. So thinking as providers, we are solution focused, right? That's our job. Prevention services, when working with active drug users, utilizes a positive service delivery model, right? Positive service delivery, which is having a strengths-based approach. We collaborate, we partner with the client and write down their strengths as a way to empower. This is an activity I've done where I might just blindly, or just not blindly, but I might have a conversation with a client about, well, what are the strengths you think you have, or what are the strengths you see in yourself? And they may not have any to name, but helping to write down and tease out can be an activity to empower the individual. Working from a positive service delivery model, we can address overlapping, intersecting, and co-occurring disorders and diagnoses. So we can play a role in kind of addressing holistic, or even asking about holistic health issues. We work and try to convey authentic interest, being mindful, working from a mindfulness perspective if you are aware or unable to, but just being yourself, not standing or sitting behind your title, not sitting behind your desk, pulling the chair out from around the desk so you're not separated by a physical barrier. Maybe sharing a little bit about who you are, where your family's from, if you are non-native. Building a relationship, building that trust, is one way to convey authentic interest. As I had mentioned before, acknowledging and providing support for positive steps already made. Again, someone picking up the phone to schedule an appointment and then is one positive step, but then actually following through and coming into their appointment is another positive step. Acknowledging that's great. That shows that someone is taking charge of their health and wellness, right? As I mentioned earlier as well, frontline workers are excellent advocates. They have a perspective that allows them to see the emerging trends that are taking place in the community. And working from a positive service delivery model supports environmental change, thinking about one's own environment and how that contributes to risk is also on our minds. Okay. Wow. Well, thank you so much for your time this morning. I would be happy to take any questions or comments. You also have my contact information on the screen, so please feel free to reach out if you have any questions later. Thank you.
For their alcohol and drug exams, and so we'd encourage you to review these, and we have all of our previous sessions on our YouTube channel, so take a look at that sometime too, and feel free to email me if you have any questions about that. So I don't see any other questions at this point. Matt, did you have anything else you wanted to say before we finish? Wonderful. Thank you again, Matt. And thanks again to everyone for being with us today. And yeah, we hope you you stay cool and be safe, and we'll hope to see you next time. Thanks again.